Well, good morning and good afternoon. Welcome to this session on vaccine hesitancy. And we're really happy to have you here. And this is vaccine hesitancy in regards to the COVID vaccine. And I'd first like to start by introducing the moderator, Craig Cohen, who is here from the University of California, San Francisco and UC-GHI. And I will actually introduce each of the speakers in turn as we come up. I'm actually going to start with an introduction to the session and then speak about each of the speakers in turn. So welcome. So to start with this session, sorry, let me just try to put this in. Really, this entire thing is on COVID-19 vaccines and vaccine hesitancy. My name is Monica Gandhi. I'm a professor of medicine and the director of the UCSF Center for AIDS Research here at UCSF. And what I want to first talk about are actually the WHO approved vaccines for COVID-19, because we're going to be talking about worldwide different reasons for vaccine hesitancy across the planet. So we are in this fortunate period in the COVID-19 pandemic to actually have 8 unique vaccines approved by the World Health Organization for COVID-19. You can see here that except for Sputnik 5, which is actually pending approval by the WHO, all 9 of these are approved, and the top 6 in some way involve the spike protein. So we're very familiar in the United States with the top 3, which are the Moderna, Pfizer, and Johnson & Johnson products, but below that are AstraZeneca, Novavax, and Sputnik 5. They all involve the spike protein in some way. And then the bottom 3 are all whole inactivated virion vaccine candidates. And the Sinopharm and Sinovac are made in China, and Bharat Pharmaceuticals makes Covaxin, which is in India. So when I say that the 6 top vaccines involve the spike protein, of course, the spike protein is the piece of the protein that sticks out from the virus, sticks out to and connects to the host cell via the receptor binding domain. And of those 6 that somehow involve the spike protein, 5 out of 6 of those involve coding for the spike protein. So to be more specific, the Johnson & Johnson product, AstraZeneca, and Sputnik 5 are all DNA adenoviral vector vaccines, where the DNA codes for part of the spike protein surrounded by an adenovirus that brings it in as just the carrier. And that DNA is, of course, transcribed to mRNA, then translated into protein, a piece of the spike protein, and then the immune response is generated against that spike protein. The Moderna and the Pfizer vaccines are mRNA vaccines, very novel technology, which again is just brought in by a lipid biomembrane, and then the mRNA is coded into the spike protein itself, and then an immune response is raised. And then the Novavax vaccine, which is approved worldwide, but not yet in the United States, is pending as of January 31st in EUA application, is a more traditional vaccine, which is actually the protein itself combined with an adjuvant. And then the 3 whole inactivated virions vaccines we'll talk about in a minute. It is important to remember when we talk about boosting, when we talk about how often to give these vaccines, that they do raise antibodies, but of course they also raise cellular immunity. And the 2 types of cells that all the vaccines raise are both T cells and B cells. B cells are the template to make more antibodies in the future if you see the virus again, and T cells help the B cells make antibodies and directly attack the pathogen. T cells are important because they actually protect us against severe disease. So we've seen very enduring protection of even the 2-dose vaccines in younger populations against severe disease because of the power of the T cells. And antibodies are going to come down with time. It's completely normal, natural. We can't keep all that protein in our bodies. But as the antibodies come down, we have the template to make more in the B cells. So when we decide on boosting, we have to remember that it's those who need their neutralizing antibodies temporarily up in the setting of a surge that will need a boost. Of all the 6 spike protein vaccines, just to remind you of what I just said, the 4th column shows that in the phase 1/2 trials, not only did neutralizing antibodies get raised by these vaccines, but they all measured T-cell immunity to the virus as part of their design. And so in the original clinical trials, which is the 6th column, you could see that severe disease was almost 100% protected against in the original clinical trials for all the spike protein vaccines. And this was true of the 3 inactivated virion candidates, the Bharat, Covaxin, Sinovac, and Sinopharm, that at least in the clinical trials, they also raised T-cell immunity and had strong, almost, 100% protection in the clinical trials against severe disease. The waning of immunity since has again been due to antibody waning as the variants have emerged.
Sorry to interrupt, Dr. Gandhi. Your slides are not advanced.
Oh, so you are not, okay, so where have you been?
On your intro.
Oh my gosh, I'm so sorry.
Oh, it's okay. You just have to wait. We look forward to seeing the slides.
Were you, let's see, were you, let me, so can you see these advanced now?
Yes, we can.
Okay, I'm not going to actually put it in slide presenter then. Maybe that's the problem. So I was showing you before all 9 of the vaccines, and sorry, I've just been talking out loud. And this was again a picture of the spike protein vaccine. This was a picture of demonstrating the DNA vaccines, the mRNA vaccines, and the Novavax, which is a spike protein vaccine. This was a slide showing you the immune response that is raised by the vaccines, both the T-cell immunity and B-cell immunity. And then we were on the slides where I was showing you the major clinical trial findings, which in column 4 here show you that T-cell immunity is raised in addition to antibody responses, and the strong protection in the 6th column from severe disease across all the clinical trials. So the important thing to remember if we have raised cellular immunity to the vaccines is that T cells and B cells continue to work against the variants. It is the antibodies that have been affected by the emergence of the variants. For example, the Omicron variant has 32 mutations across its spike protein, which means the neutralizing antibodies do not work as well. But the B cell immunity, when it kicks in and starts producing new antibodies, will produce antibodies directed against the variant. And I refer you to this very nice science paper in the bottom left that speaks about the adaptation that the immune system makes to develop antibodies directed against the variant. And then T-cell immunity, because it's so robust and in breadth, has been unfazed, at least so far, by the emergence of the variants, including the Omicron variant, and so that you have continued relative protection against severe disease with T-cell immunity generated by the vaccines. So of all 9 of those vaccines made by the WHO or approved by the WHO, you can see that at the beginning of the campaign that the WHO actually did not recommend booster shots for any of them until relatively recently. And that was in the face of global vaccine inequity and recommending that essentially before rich countries give out booster shots that we distribute more 1 doses across the world. However, the Sinovac and the Sinopharm vaccines have an adjuvant that's co-formulated with them that is actually not as strong. Unfortunately, because of that, they really are 3-dose vaccines, especially for older people. So in October of 2021, the WHO did back a 3rd dose for Sinopharm and Sinovac for older individuals. And then later in the campaign, when vaccine supplies became less of an issue, the WHO has recommended booster shots for those at risk for severe disease. The Covaxin vaccine this is the Lancet trial showing its whole inactivated virion candidate. It is 93.4% effective against severe disease, and it has continued with its effectiveness through the booster shot campaign in India among healthcare workers. However, it's likely so effective because it has an adjuvant that is funded by the NIH, which is really powerful to induce immunity. So whom do the boosters most benefit when we go forward and talk about vaccine hesitancy? It really does seem to be older patients. The data from Israel, the UK, and the US with the booster campaign has really verified that those over 65 has the most benefit from the third shot. And when we talk about the fourth shot here in this country, there was a New England Journal study among Israeli healthcare workers just published last week that didn't show a benefit of the fourth shot to those 50 to 64 healthcare workers in Israel, either for vaccine effectiveness or bringing down the viral load. So the fourth shot campaign, at least except in the United States, who authorized it for 50 and above, is really been only authorized in most countries for much older patients, over 70 in Germany, over 75 in the UK, and over 80 in Quebec and Sweden. So who remains unvaccinated here in the United States? Well, unvaccinated individuals tend to be, in the US at least, younger, less educated, and actually more of a certain political party, which is Republican. So you can see here, this is data from the Kaiser Family Foundation, that younger individuals are more likely to be unvaccinated. We actually have a very high rate of vaccination in this country among over 65-year-olds. And unfortunately, it is trending by political party, and so among unvaccinated adults, among Republicans specifically, unvaccinated adults, 61% are Republicans. Education is also a major factor that plays into not taking the vaccine in this country, and there has been a major attempt to increase vaccine uptake in this country, and strategies that have been used are, for example, community-based messaging in those communities who had traditionally been more reluctant, which were Black and Latino communities. Luckily, vaccine uptake has increased prominently in those communities with community-based messaging. Incentives have been used in this country, and really just with time, that's what's happened in terms of increasing vaccine uptake. In fact, we're now at 82% first dose out given for over 5 years old in this country. So I will actually now turn it over to our panelists, and I'm really honored to introduce our first one. And sorry about my computer difficulties this morning, and I hope that you could all hear me. In fact, Craig, I'm so sorry. I'm still having a problem with my computer and can't seem to bring up the order in which you wanted the panelists. And so I'm going to let you actually introduce the first one.
Hi, everybody. As Monica mentioned earlier, I'm Craig Cohen. I'm professor at UCSF in obstetrics and gynecology and also co-director of the University of California Global Health Institute. Good morning, good afternoon, and good evening for some of you. Our first speaker is Adeeba Kamarulzaman, who is the Dean Emeritus of the Faculty of Medicine and Professor of Medicine and Infectious Diseases at the University of Malaysia. Adeeba, over to you.
Thank you very much, Craig. Thank you all for inviting me to share some of the experience over in Asia generally, but more specifically in Malaysia of the vaccine rollout. Asia covers a very big geographic footprint, so I'm perhaps going to try and concentrate on Southeast Asia and Malaysia in the context of our experience with the vaccine rollout, and also on the problems of hesitancy. Just very quickly, are you all seeing the slides? And it advancing?
Yes.
Okay, great. So overall, in at least the ASEAN region, comprising of Malaysia, Singapore, Vietnam, Indonesia, and countries that you can see there, the vaccine rollout has been somewhat successful with high vaccine coverage in comparison to many other regions with the primary vaccine program. In As you can see there in Singapore, South Korea, Brunei, my own country, Cambodia, this up until February, March of this year, many countries in the region have achieved upwards of 80% primary vaccination program in adults and adolescents, and many are now embarking on booster as well as child vaccine for children 5 to 11 years. Here's some very recent data from the WHO Southeast Asia office that shows a wide range. Although I said in the ASEAN region we're doing reasonably well, including and also South Korea, Australia, obviously, but there are also some countries that are not performing as well, and that's reflective also of the socioeconomic levels of these countries, including Nepal, Myanmar, and Bangladesh. In Malaysia, the Malaysian government had taken a very, very proactive effort towards procuring vaccine from the early stages, initially from COVAX, and then directly bilaterally with Pfizer mostly, but also 30% of our vaccine program is with Sinovac, and a smaller proportion with AstraZeneca Oxford vaccine, and much smaller again with Sinopharm. So safe to say, I think the majority will be the Pfizer vaccine, followed by Sinovac. And to date, as you can see there, we've really achieved quite high levels of primary vaccine program. Adolescents 12 to 17, and we're now rolling out the childhood vaccination, which is having a little bit more of, I wouldn't say hesitancy, but slower uptake. It's not as rapid as what we saw with the adult vaccination, which happened at the same time as the country was being hit with a really, really severe Delta surge between May and September of last year. With regards to vaccine hesitancies, this is a survey that was done for the 6 ASEAN countries on the UK's YouGov. As you can see, the level of hesitancy within 6 months of the 2 surveys had decreased quite significantly in all of the countries that were surveyed. And interestingly, Thailand and Vietnam never really had a big problem of vaccine hesitancy, but 6 months later, the level of acceptance for vaccine was very high, as was then translated into the actual vaccine coverage that I shared earlier. And here, again, in this ASEAN report, again, very high levels of willingness to be vaccinated in countries within the ASEAN region. Or it's all bunched up there, but for nearly all of for most of the countries, it's 90% and above of the population willing to get vaccinated. Now, that's not to say that we don't obviously not have a problem of hesitancy. There have been multiple surveys done either in country or regional survey, usually with relatively small sample size, but nonetheless, I think gives us an idea of the kind of demographics of people who are less likely to be willing to accept the vaccine and some of the risk factors for vaccine hesitancy. That includes those from lower socioeconomic background and countries, like I shared before, that have a lower GDP. The one that was done in Malaysia, I think, similar to many countries, although again the rate of vaccine hesitant respondents in this particular survey was small, but what of those who identified as being less willing to be vaccinated, the reasons for that is similar to, I think, many around the world. One of the most predominant is a mistrust of the mRNA vaccine, thinking that this is a very new technology, not true and tested extensively, coupled with the widespread misinformation and disinformation. And also, quite initially, when the program was being rolled out, we thought that issues like ethnicity and race and religion might play a role, but thankfully, this was not to be so, except for a very, very small minority of people. So at least for Malaysia, the reasons for the small pockets of vaccine hesitancy had to do with concerns around the effectiveness and safety of vaccines. Unfortunately, about the same time as our troubles with COVID-19, particularly the Delta wave and surge, there was also quite a bit of political instability. And so that kind of didn't help, because there was a background mistrust of the government for many different reasons. And that also translated into a high trust deficit towards the policymakers and Ministry of Health, JKJV's, the vaccine committee. Like a little bit like what Monica presented, younger participants had perceived less risk for COVID and were a bit more complacent. One issue that we did see was the Malaysian government relied quite heavily on using digital appointments, etc. So it's not so much hesitancy, but gaps in access to technology. And so there was delay in particularly rural areas and the older community who may not be as digitally savvy. So delays in making appointments and actually getting vaccinated. And then, of course, huge problems with misinformation, WhatsApps that were going around about Bill Gates and Pfizer, and similar to being experienced, I'm pretty sure, all around the world. Now, if there's one country that I guess we've all heard about the issue of hesitancy that's now being played out in terms of the COVID-19 incidents is Hong Kong. And really, it's hard to understand the level that as you can see from my earlier chart, despite having great availability of both the mRNA vaccines as well as the inactivated vaccines, Hong Kong had a particular problem amongst their older populations with vaccine hesitancy, unlike what we experienced in Malaysia, Singapore. And of the publications that I've read, it also has to do with a mistrust of the mRNA vaccine as well, and concerns about efficacy and safety. Thankfully, I think there's been some improvement. Now, one interesting aspect, I think, from our part of the world, because of this of wider use of the inactivated vaccines, is the kind of the dichotomy between those who trusted the so-called Chinese vaccines and those who didn't. As you can see here, it's quite interesting. This is the top two surveys done in Indonesia, and it's kind of split between those who trusted and those who didn't trust the inactivated Chinese vaccine. There was no real difference, but for the Thais, there was somewhat better acceptance of the newer vaccines, and it seems to be different for different country. In my own country, although we have not really looked at the preference for in terms of a survey, but anecdotally, for those who opted for the Sinovac vaccine, they're adamant that they wanted the third and subsequent dose to be the Sinovac vaccine because of this mistrust of the mRNA vaccine, even though the Ministry of Health had kind of almost decreed that they should be receiving the mRNA vaccines following the results that Monica shared earlier. Initially, the Minister of Health was going to make it compulsory that, particularly for the elderly people, that the third dose that they receive should be an mRNA vaccine. But against strong resistance, I think the Ministry of Health relented and said, a third Sinovac is better than nothing. So there seems to be, although these studies showed that in Singapore, the population were not so keen on the so-called Chinese vaccine for lack of results and published results, but in certain population, the inactivated Chinese vaccines were preferred. And again, anecdotally, when speaking to my patients and others, there was this sense of pride in an Asian vaccine was one of the other reasons given, and or for preferring the Sinovac vaccine. And the third was third reason, apart from fear of the mRNAs, the third reason given was also within Chinese traditional medicine practice. Apparently, it's not a good idea to mix vaccines. So, different cultural attitudes have resulted in different responses, I think, towards vaccine willingness or hesitancy. So this last slide, just quickly, how we in Malaysia overcame some of that hesitancy. There was a very big drive to get religious leaders right from the very, very beginning. Religious leaders were engaged through experiences in the last few years of general vaccine hesitancy towards childhood vaccination program. The government had very early on ensured that religious leaders came out to say that these vaccines do not contain porcine material and are halal, etc. And also for vulnerable, marginalized populations like the indigenous population, migrant workers, and so forth. We also engage respective community leaders to get them on board. And finally, the government did have kind of vaccine mandate for even going to mosques and churches, and also restaurants and other places where proof of vaccination was required. And I think that, coupled with the rather horrific experience we had with the Delta surge, all helped to increase the vaccine uptake in Malaysia in the end. So thank you very much. So that would be my sharing for now.
Thank you so much. So we're next going to turn to Heidi van Rooyen, who is the Executive Director of the Human and Social Development Program of the Human Sciences Research Council in South Africa. And Dr. van Rooyen will specifically share her experience and share the experience from the South African region.
Thanks very much. Good afternoon here from me to all of you who are joining us for this talk. So I'm going to be focusing particularly on South Africa, and particularly talking a bit for the bulk of the presentation on what do we know about hesitancy in South Africa during this COVID period, and what do we know from a survey, various surveys that we've, large representative surveys we've done across the country. And in my concluding comments, I'll say something about how is that translated into actual vaccination rates and what are some of the issues that we've seen there. So the hesitant, oops, trying to move down. It's not working so well. There we go. The hesitant in our view, and certainly I think for many of you who are talking about those who are hesitant, we're not talking about those who are denialists, who are anti-vaxxers. They're those that sit in that middle space of uncertainty, doubt, and decision, unsure for a range of reasons as to whether or not they should be taking the vaccine. And in South Africa, we used a series of surveys, one done by our institution, the Human Sciences Research Council, together with the University of Johannesburg, and another series of surveys through the National Income Dynamics Study Group. And these surveys were conducted at various points through various platforms, and we think managed to get to quite a wide range of the population, with a view to doing a couple of things across these surveys, both with getting a sense of what were South Africans' views around vaccines, and what could be driving, what were their views around vaccine hesitancy, what was causing some of that uncertainty, and just general perceptions around COVID-19. And I'll talk particularly here about some of the views around acceptance and hesitancy. So these surveys have been conducted at various points from April 2020 to July 2021. They give us a very useful kind of trends over time of what the mood and what the temperament and temperature is in the country around vaccine hesitancy. And you can see that over time, vaccine acceptance was quite high. Roughly 7 in 10 people were of the view that they would be accepting of vaccination, they would take vaccines as and when they became available in the country. Those that were motivated and were high in acceptance were motivated by a desire to do so for others. So this real idea of, if I'm vaccinated, that's of benefit to others, and that was a big motivator and driver. We did see some differences with respect to race in terms of what were the motivations and views driving that. In the US, much more strongly along party political lines, but in South Africa, not necessarily party political lines, but certainly those demographically white, stronger views about not so much for others, but concerns about civil liberties perhaps, and about individual rights, and not being told to do something by government. So high acceptance rates we find in these nationally represented surveys. For those who are hesitant, roughly about a third of the population remaining hesitant about taking the vaccine, there are kind of a set of familiar reasons that present themselves. People were worried about side effects, worried about the speed at which it all happened. I think many of us still are surprised that science could move so fastly. Those of us who are not into science, I think, who don't understand science, that fed a lot of views about how good are these vaccines. They happen so quickly. They've never happened so quickly before. Should we be trusting them? So worried about side effects, do not believe that it's effective, which is the point I was just talking to now. and people who were against vaccinations. And again, a similar theme as is coming from the US and Malaysia, those who were against vaccination, just a sense of distrust of either the vaccine or distrust of government who were rolling out, who seemed to be quite central in the rollout of vaccines. And we saw that across both groups. With respect to age, 18 to 24-year-olds, we saw higher levels of vaccine hesitancy in that particular age category. I'm just looking for my next slide. So young people, 18 to 24-year-old, their reasons for being hesitant was not very different or distinct from other age groups. So similar kinds of concerns: side effects, ineffectiveness about the vaccine, and worries and a sense of distrust about it. Vaccine hesitancy was significantly higher amongst respondents who reported social media as their trusted information. So now particularly looking at that 18 to 24-year-old group, those who relied on social media as their trusted source, and pretty well known. We all know that younger people are much more reliant on this, and so we saw this in the data as well, that among those young people, vaccine hesitancy is significantly higher among those who reported social media as their trusted information source. So I've run through very quickly. We had run about 8 minutes. I'll try to keep to the time. I'll talk a bit about what did these surveys tell us, and then I'll talk a bit about where we are at vaccination rates, and perhaps just say a bit more about what does it mean for us in South Africa. So the surveys told us some really interesting things. General upward trends in acceptance: more than 7 in 10 adults have either been vaccinated or would like to be vaccinated. But we saw some variation and change across social pockets. And certainly one of the things we've realized as we've gone into implementation and rolling out the vaccine is this need for much more targeted interventions. This idea that a one-size-all approach works for everyone. So whether that's an older Black woman in a rural community, a young person who is predominantly using social media, this real understanding that if we are going to be successful in ramping up those rates of vaccination in the country or addressing those who are hesitant, we have to be looking at much more targeted interventions that speak to where they are, what their concerns are, and speak much more directly to that. A kind of middle of the road blanket approach we know is not going to work. We saw high rates of hesitancy among young people, and these have become the focus of communication campaigns and much more research about their concerns and what it is that they are worried about. And if we try and dig a bit deeper in terms of what's driving some of the concerns among young people, again, it's a similar issues: a lack of trust in community leaders, a real sense of concern, of trust in government who are rolling this out, and just really feeling like politics, and this is across the country, politics has played a bigger role in vaccine development and is shaping again some of these hesitant views. Ongoing concerns about the side effects and effectiveness of the vaccine. And so in some of the work that we've been doing in trying to address this has been saying that the communication campaigns need to be much more targeted, have to be much more specific in talking at the really basic level that addresses some of these issues around side effects and the effectiveness of vaccine, and also finding ways to talk about these things in a language that people understand. So we speak science, we speak the language of science, and having a scientist translate some of those messages in ways that are meaningful and that are useful, we were saying were particularly important in trying to address the hesitant. We need communication platforms to target the social media space and multiple other platforms. So there have been some interesting innovations in this last while about changing up the messaging and using other methodologies and ways of reaching young people who use these social media platforms as a way to speak to them and to speak to their concerns. Inequalities in the vaccine rollout need to be addressed to maintain trust and acceptance. I'll say a bit more about that in a minute. And certainly this comment is important about who do we use to promote communication about vaccines going forward. And so a lot of confusion, as in many countries, vaccines became a political issue. We have, and the response in South Africa has been, I think, to a fair extent, science-based and informed by groups of scientists, as it is around many parts of the world. But a lot of that messaging, a lot of who was holding the space, a lot of who was giving the message around vaccines were politicians who were claiming it, owning it. And so I think that was confusing for the population in terms of not always trusting the voices from which the information about vaccines was coming. And there's a sense in which we're saying, keep it clean, keep the scientists, keep the health workers, keep the medical personnel on the front line, keep those voices communicating about vaccines and not politicians as being the front of that. I don't think we've got that right, and there's still much more to do. So the surveys are really giving us a sense of who are the hesitants, what does vaccine hesitancy look like in South Africa, what are the percentage of population who are hesitant, what does it look like in South Africa, who are more hesitant than others. So how did that translate then into kind of vaccination rates? Our vaccination rates in South Africa are, excuse me, really low, around about 49% of the adult population have had a vaccination. And if you look at that demographic spread across the different age groups, higher rates in the 35 to 49, 50 to 59 categories, and 60 plus, and lower rates of vaccination among those young people. So in some ways, supporting some of what we've seen, we saw in the vaccine hesitancy survey data. So what does it mean for South Africa, which is, many of you know, I think our first speaker talked about, second speaker, inequalities in Malaysia driving some of those low response rates, vaccination rates that you saw. And I think it's an important point for us here in South Africa too. And I want to conclude on that point. Vaccine hesitancy is very much about individuals' hesitancies, concerns, uncertainties about whether or not the vaccine will be good for them and whether or not they should take it. But vaccine hesitancy, in my view, is also about a whole range of other issues which have to do with much more social and structural issues that inform whether or not, even if somebody makes a decision to take the vaccine, to get vaccinated, influences their ability to follow through on that. So it's not just a matter about of individual behavior and individual choice. Here in South Africa, I think, as in many parts of the world, it's also driven by a number of those inequalities. So we've been saying a lot more about the drive for vaccination. If we're going to ramp up that really horrible 49% of the adult population who are vaccinated, if we're going to ramp that up, we have to be thinking about a couple of things. We have to be targeting and thinking about where those rates are low, and we have to think about that across geography and region, because that's all very different, and race in South Africa, which is a big kind of factor, class, etc., etc. We have to think about it along all those levels, and we have to be thinking about much more, as we did in HIV and with other diseases, thinking about how do we take vaccination to where people are. So often the requirement is, here's a vaccination site, here's a central place, go and get your vaccine. So many factors we found in our much more local ward-based studies of what are the drivers behind vaccination, the things that are driving or limiting uptake are those issues around access, are around communities that are really quite impacted by COVID. Unemployment levels are high, food security, insecurity is high. And for those communities and those groups on the ground, the idea of taking the vaccine is not a simple one. To follow through on that action requires much more. And we're saying we should be shifting in this next period about getting vaccines closer to where people are, if we hope to kind of reach some of those numbers. And we have to speak to where people's issues and concerns are if we hope to convert them into that successful vaccination rate. So I'll conclude there. I'm sure there'll be questions and comments later on. Thank you very much.
Thank you so much. And our third talk actually now is by Dr. Guilherme Werneck, who is a professor at the Department of Epidemiology at the Rio de Janeiro State University. And specifically, we'll be talking about in Brazil, vaccine hesitancy and across the continent. And then we will go to the final talk and then have our panel. Thank you.
Hi, everybody. Good morning from Brazil. Thank you for organizers for inviting me to be here, and in particular, Craig and Monica for organizing this roundtable. I'm going to share my screen. Let's see if it's going to work. Okay. Oops. Can you see that? So I'm gonna talk a bit about the issue of vaccine hesitancy and COVID, focusing in Latin America and particularly in Brazil. So I'm going to start saying that, you know, in general, in the last 20 years, vaccination coverage for most of the large countries in South America and for the childhood vaccines have been high. You can see here for the first dose of measles, for the third dose of diphtheria, pertussis, and tetanus vaccine, and for polio, for Argentina, Mexico, Colombia, Brazil, and Peru, that most of the time in the last 20 years, they have coverage above 90% for all these vaccines. But in the last 5 years, before the pandemic, some countries, in particular Peru, Brazil, and Mexico, have shown a decrease, important decrease in vaccine coverage, which is not exactly well explained in these countries. Before the pandemic, lack of confidence on vaccines had not been attracted much attention in these countries. In this survey in 2015, for instance, less than 5% of the population surveyed in Argentina, Ecuador, Brazil, and Colombia, they said that the vaccines are not important for children, and they agreed with the statement that they do not think that vaccines are effective, in contrast with many other countries in which the problem seems to be worse. In particular, it's interesting to see Mexico here with more than 10% of the population agreeing with the two statements. I think this is important because since the question of vaccine hesitancy was not considered as much of a problem in these countries, we don't have a lot of literature before the pandemic on this issue in these countries, in particular in Brazil. 3 years later, another survey than in other countries in Latin America, focusing on the same questions, they found that a lack of confidence measured by the same questions actually increased in most of the countries. And although in Mexico, it seemed to have decreased at this point, but it's still less than 10% of most of the countries. People from these countries actually have confidence in vaccination. Before COVID vaccine availability, we have some surveys in different countries in Latin America that actually raised some concerns about what would be the rollout of vaccinations in Latin America. For instance, in Peru, in January 21, just before vaccination started, when asked if the Ministry of Health made vaccines available, only 26% said that they would go to vaccinate without any doubt. And 43% would say that we will prefer to wait to see what happened to people that will vaccinate. And 12% said that they will never vaccinate. In Chile, in August and September 2020, 23% of people were not willing to vaccinate with a free vaccine with 95% effectiveness. And in June 2020, 15% of Brazilians were not willing to vaccinate, 25% from Mexico, and almost 30% from Ecuador. So just before COVID vaccine started to roll out, this was something that raised some questions. However, what we saw is that these surveys before vaccine availability were not actually that predictive of the rollout of vaccination in such countries. For instance, Chile, Argentina, Peru, and Brazil, they actually performed well in vaccination coverage above, for instance, the average of Europe and the world. And Chile got like 90% of people vaccinated at this point with at least 2 doses of the vaccines. And Argentina, Peru, and Brazil between 75 and 80% at this point in time. I want to just open a parenthesis to talk a bit about the Brazilian situation. I guess most of you know that Brazil has had a pandemic preparedness and a pandemic dealing with the pandemic in a wrong way in different aspects. But one point that I want to raise is that that was the first time in at least the last decades that Brazil faced a large movement against one vaccine. As far as I know, the only time that we got like a large movement against vaccination was in the start of the 20th century in Rio de Janeiro in 1904, in which we had like what was called the vaccine rebellion against the compulsory vaccination for smallpox. And since then, we never had like large movements or large campaigns against vaccines in Brazil. But at this time, actually, we have that. And unfortunately, most of these messages and misinformation messages came from people that were in the federal government, saying that, for instance, vaccine will turn people into crocodiles, that COVID vaccines will raise the risk of getting HIV infection, or the president saying that he's not going to be vaccinated and his daughter is not going to get vaccinated. And these things were amplified by different people from the country. So this thing is really a different thing happening in Brazil at this time. And this was willingness to vaccinate was related to support of the federal government. For instance, just in the beginning of the vaccine rollout in Brazil in January 21, those that support the president, 25% were not willing to vaccinate at this point in time. And the value was 12% for those who do not support or did not support the government at this point. 1 year later, things changed a bit, but still those that support the president, only less than 70% actually have vaccinated, compared to almost 90% for those who do not support the actual government. The interesting point is that not willing to vaccinate almost disappeared. People who didn't vaccinate actually were willing to vaccinate anyway. So it seemed that by the end, this campaign or this movement did not have a large impact in vaccination coverage in Brazil. I think that we don't understand much about that. What are the reasons for we reached high levels of vaccine coverage in such a diverse context? But I think we still have low levels of vaccine hesitancy anyway. There is a culture of vaccination in Brazil. There is a national immunization program since 1973 that gives free vaccination for people for different diseases. The risk perception might be high because the country was hard hit by COVID. We have a universal health system with large number of primary health care units and a large family health program covering more than 2/3 of the population. We make access to vaccination easy to everybody. There was a large commitment of managers and technicians in different healthcare and managed levels, strong engagement of scientific and professional societies and NGOs supporting vaccinations. And actually the evaluation of the government decreased a lot during the pandemic. So I guess most of this stuff together may explain why we actually reached high levels of vaccinations even in this adverse context. However, there are still challenges. The booster dose still have like less than 50% of people from the target population that actually did not vaccinate. Coverage of the second dose for children is still 15%, and there is a high social and geographical vaccination in vaccination coverage in Brazil, and possibly also hesitancy rates, pockets of hesitancy rates in Brazil. So that's my message. Thank you very much.
So much. That was excellent. And then we're going to end with our final talk, who is specifically, before we get to our panel and the questions that you've been asking. This is Dr. Heidi Larson, and she is the founding director of the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine. And so we'll bring it all together in her talk. Thank you so much, Dr. Larson.
Thanks. Let's see. I think a lot of ground has already been covered, but I'll contribute what I can to it. Thanks so much, and really appreciate the presentations. I founded the Vaccine Confidence Project 12 years ago, and I spent a lot of time thinking about it, and I learned some things today that I really appreciate, because I think once we get down to these local levels, the kind of tangible issues become much more real, and I think that's really important for us moving forward. The ask for my talk was about WHO vaccine hesitancy strategies, but I'm going to detour from that. I'll tell you about the beginning of when WHO coined this term. This was a term, vaccine hesitancy, that the WHO SAGE group, the Strategic Advisory Group of Experts on Immunization, decided they wanted to call this kind of questioning crowd hesitant, and convened a working group, which I was on. There were about 12 of us. And the ask was, give it a definition. I mean, give a definition to the term we're giving you. Map out what you see as the issues, and are there any strategies? So this was it started in 2013, 2014, but came up with this, refers to a delay in acceptance or refusal of vaccines despite availability of vaccine services. That was an important one because we wanted to make sure we distinguished this undecidedness and hesitancy from access issues. And that's really an important distinction, although they do affect each other. When people don't have access, or it's difficult access, that can make people hesitate even though they might want the vaccine. It's complex and context specific. I think we just heard that in the different presentations. And the group came up with this term, which I think originally came from WHO Euro region, the 3 C's: complacency, just don't need it, don't want it, but something I would tag to the flu vaccine is a common thing. And in the context of COVID, I would say that particularly those who don't even believe that COVID exists why would you think about wanting a vaccine? But also, I think with the younger population, there's a sense that they don't need it as much as adults. Convenience, that's access, but access to the extent that it affects people's willingness, and confidence, the trust. When we unpacked that and looked at the different factors, confidence was really a big one. We came up with a model that broke down the different determinants. We did, I led a big systematic review of everything we could find. As the term vaccine hesitancy wasn't really in circulation yet, or was just occasionally mentioned, we broadened it out to questioning and just the relevant characteristics of hesitancy. And we found 3 major domains, and it was, and I think they're still quite relevant. The vaccine and vaccine specific issues, or vaccination, the safety of the vaccine, the schedule, because one of the issues was too many vaccines too soon. The concerns about new vaccines, which we've heard in the previous presentation, costs, very risk benefit, but specific to the vaccine. And then there's the individual and group, personal experiences with past vaccination, just the whole, the immunization pattern, like we just heard from about Brazil and South America. Actually, there's a culture of immunization. It was in my years in UNICEF, it was always the poster child of region for immunization. And finally, contextual, and that gets out to the political. So this we published in 2014, almost 10 years ago, but there's been an escalation in work in this area, and it's taken another escalation in the context of COVID. But I do think these are the key, and I think we've heard them in the previous presentations. In 2015, we also did a global mapping, which I think is where Guillermo's map figure on South America, came from. We did the first kind of global mapping of vaccine confidence. And one of the findings when we did the analysis of all of it is sometimes the solution lies outside of the vaccination program. And I think that's come up in a few of the presentations, but it's not just about the facts for the vaccine or the interaction between. Most of the research we saw a decade ago was much more the interaction between the patient and the healthcare provider. There was not a whole lot on these broader issues that now we're seeing are so influential. And as we just heard, it's with Heidi from South Africa said it's often driven by issues beyond the vaccination, and that makes it tougher for immunization programs because it's beyond their scope of work, so to speak. But what I think it's prompted is a lot more partnering. And I came into vaccines from working in AIDS for a decade or more, and really saw such a dramatic difference between the AIDS movement that embraced and had some of the most diverse partnering, and immunization and vaccines were pretty narrow, pretty siloed, even within health, and sometimes vaccine specific and not even across vaccines. And I think one thing that COVID has done for us has pushed us to, partner with whoever we could. And I think that's been a gift, if one can say, in such a tragic time. But I hope we hang on to this. I mean, we have seen, and I think this has come up in some of the other presentations, the importance of looking beyond, finding out what has meaning to the people we're trying to serve, what's relevant to them. And I think that came, I think it was also, again, Heidi that said speaking to their concerns. And I think that's really important. And it's not just about the messaging, it's very much about the who. It's in the case of, we saw some of the interesting engagement with barbers, barbershops and hair salons in the US and some of the Black community, which are far more than just a place to get your hair cut. I mean, it's a gathering place, it's a sharing information, and it's a familiar. I do a lot of work on risk. And one of the huge things about people's thresholds for risk and their willingness to trust is familiarity. Familiarity and voluntarily, and with COVID, we have an absolutely unfamiliar, uncertain new vaccine, and in many cases it was required. So you've got two domains of people's heightened risk, and that's a sense of unfamiliarity and involuntary in a lot of cases. In Bhutan, it was religious leaders and Bhutanese monks who blessed the vaccines. He's walking around with the vaccines that came in, the COVID vaccines, with the incense, and that brought values and meaning together with science. And I think sometimes when we talk so much about science, stick to the science. Well, sometimes I think we have dehumanized it and need to bring back some of this context, which has come up again in the previous situations. Trusted leaders, that's also come up. It's so important. We talk about trust in government as being we do have a huge trust deficit globally, and in all of our research, we've seen that in our COVID vaccine research, more than any socioeconomic demographic correlate with vaccine acceptance, the biggest one in the context of COVID vaccines has been trust in government, and it's not by a small margin. But what do we mean when we say trust in government? Because I think that's been used a bit too loosely, because there's national government, there's local government, there's, are we talking about government institutions, government policies? I think we need to do a little better about unpacking that. But we just heard in the situation of Brazil, and we had the similar thing with the US, of a leader who is basically taking people away from the science. And that's a whole other, I think in all our preparedness plans, I think a lot of our assumptions, or at least certainly some of them, were wrong. We assumed in the face of a fatal pandemic that leaders would line up, that they would come together, and that they would believe in the science. The whole issue of patient experience, I think, is become very clear how important that is. It's not just about the vaccine, it's people wanting to feel, as I said, comfortable, familiar. I mean, to the point where with the barbers, they didn't just use it as a place where the barbers shared information and tried to build confidence when they were cutting somebody's hair, but that at one point they started giving vaccines in the barber shop because it was familiar, because it was comfortable, because it built some confidence. It was one issue we had in the UK with the big tents set up in different settings for the mass vaccination. We had particularly some of the elderly who wanted to go for a walk to or go see the place before they went there for their vaccine, just to know this isn't where I normally get a vaccine. What's going on here? Help familiarize me before I have to go for the vaccine. I just have a last couple of slides here. I think that the importance of seeing evidence beyond the science is really important, and again has come up across the different things about values, politics, familiarity, culture, age, young people and older people. I mean, we've seen in some of the data, Hong Kong has been the most public, but Singapore actually did have issues with some elderly situations, and some of the elderly really not wanting, the super elderly as they call them, not wanting, being afraid of this vaccine. And when we did some local research and our collaborators there, the reasons were, one, my grandchild is showing me, all the bad stuff about vaccines and it scared me. And the other was, I live alone. I don't want to get this vaccine. And then I have a reaction and I'm alone, and I don't want to be alone in that situation. And then the other one was, I have so many other comorbidities, I don't need something else. And one would think, well, then you should get the vaccine to prevent another, but they were more driven by the risk. One of my favorite risk scientists is Paul Slovic. He's really written a lot about what I think is an absolutely missing dimension of a lot of our risk analysis. We often talk about risk and benefit, but it's always from the evidence scientific perspective, the efficacy of the vaccine. But we don't think enough about risk as feelings, risk as politics, and both of those have certainly loomed large and had a huge impact on the success or lack of it in certain settings around the world. One of my favorite examples of a country bringing together, actually it's not unlike the Bhutan situation in 2018, I think it was 2018, Adeeba would help me out here, but there were a lot of issues around the measles vaccine campaign, a measles rubella vaccine, normally a well-accepted vaccine, familiar vaccine, but a few imams decided it was halal. It was haram, not halal, and was not acceptable to the public. And even though the higher authorities accepted it, started to spiral into a lot of anxiety, and it really disrupted the campaign. With that experience and that memory, the Indonesian government not only went to their safety body to get the usual FDA safety approval, they then went to the Higher Islamic Council and wanted their blessings before they went out. So they brought both the science and values together. The last, I brought up Team Halo there. That was, sorry, I was pre-recording to try to make it tight in time. The Team Halo has been one of the collaborations that we found really successful. Team Halo is a group of, was a collaboration with a group of young scientists and researchers working on COVID, who together with TikTok and an initiative from the UN and the Vaccine Confidence Project, we're on call for people's questions, because one thing we hear quite a bit is, thank you for pushing, when we ask a question, Facebook, Instagram, TikTok, they go straight to go to NHS, go to WHO, go to CDC. And we have people coming to us and say, well, we've been there. They don't have the answers to our question. So Team Halo has come up with this TikTok rapid, so you have young doctors, young scientists, familiar, totally at ease with social media, in real time saying, we can answer your questions, or we'll do the best we can. So I think that the relevant and quick feedback is important. And the last slide that I flipped through was one of my favorite campaign themes, which is in Bolivia, doses of esperanza, doses of hope. Thanks so much. I hope I didn't use too much time there.
Thank you. That was excellent. So if all of you won't mind unmuting and coming on camera, we can start the panel discussion. And Craig, I see a couple of questions in our chat. One had one, and I'm not sure who wants to answer this, but that this is from Christina Gunther. I was just in a small village in Guatemala. Vaccine hesitancy is very high. 1 to 3 people are dying of COVID every day in the village. Reportedly, hesitancy is high due to issues of trust and racism. What is your recommendation for solving this? this is a difficult one. I wonder if anyone wants to make comments about this, and then we can go back to the first question that was asked in the chat and came over to the Q&A. We can go back to that right after this.
I'm happy to.
Heidi Van Rooyen just raised her hand. Go.
I'm happy to respond to, because I think it's similar to the other one about beliefs and religion. I think the issue around race that you're talking about in that third question, I think a lot of these solutions to addressing these beliefs and concerns are local. And so, for example, we went back and did some qualitative work at the level of communities and wards to try and understand what were some of the beliefs or issues, say, in particular race groups or religious groups that were kind of driving hesitancy. So the solutions are local. I think doing some work, going back, trying to understand what are the particular beliefs that are pushing it or driving hesitancy, and then thinking about how you would design some of your communication to speak to those issues or concerns, or to find a way of creating some meaning. So the wonderful pictures you showed us about the monks going around and blessing the vaccines is an example of that. We have to find a way, I think, of speaking to where people are at and finding a way in, because hesitancy is about a block or a barrier. That is about a set of individual beliefs, and what's a way in, and how we do that is by starting with where people are at and trying to understand what might be pushing it, what might be behind it, and how do we then target and shape our communication or our campaigns around that.
That was great. So one question that came up prior was the Corbavax vaccine, and I just want to just briefly address this. This particular vaccine was made by scientists at Baylor University. It is really, we talked about the 9 vaccines that have been approved by the WHO. Just as a reminder, Sputnik 5 has actually not been approved by the WHO. So I should say that there are 9 vaccines in prominent use, and 8 have been approved. And 3 of them are whole inactivated virion candidates, and 6 of them involve the spike protein. The Corbavax actually is the receptor binding domain, which I'd showed you a picture briefly, where the spike protein connects to the host cell, and it's combined with a very traditional adjuvant, aluminum hydroxide gel and CpG 1018. And the protein itself is produced by a yeast. And so in a way, it's a very simple process that we're very familiar with, like with the hepatitis B vaccine, which involves a piece of the protein. And so the idea of producing recombinant protein in yeast, since it's so sort of familiar in vaccine technology, the idea is that this vaccine can be made in multiple countries. It is quite exciting. It has been given patent-free to manufacturers, and right now the only country that has announced that it will be making this in bulk for its population is Botswana. This got announced 2 days ago. So I think it's exciting. The receptor binding domain is not as prone to mutations as the spike protein, which is sticking out. We haven't seen as many mutations with the subsequent variants in the actual RBD component of the spike protein. So I think that's also reassuring. But I will say, and this is something that I can bring to the panel as we're waiting for, or there are a couple more questions, but one thing I'd ask of the panel, specifically Adeeba, because you talked about this with the Sinopharm and Sinovac vaccines, is there's been hesitancy around certain vaccine formulations. And one thing I will say about the whole inactivated virion, at least the Covaxin one that is formulated with an NIH-funded adjuvant, is that it has been quite powerful to actually see the entire virus as opposed to just the spike protein when you're thinking about subsequent booster campaigns. And so we actually have a piece today coming out in MedPage today talking about the idea of subsequent boosters being with allowing you to see the whole virus, whether that be with Covaxin or another of these about 4 or 5 whole virus candidates being made in the United States funded by the NIH. So there is another question specifically for Dr.
Guilherme has
Yeah.
his hand up, Monica.
Yeah, please.
Me?
Oh, well, there is a question for you, but did you have a comment?
Yes, so I can address both, right? No,
Yes,
I just want
the
to.
question
Okay.
often also for you, and then you can address both, which is, it said you mentioned Chile, Argentina, Peru, and Brazil, and wondering if you could mention anything else about the rest of Latin America.
Okay, so I just want to talk a bit about the last question. The first question that, in Brazil, regarding the question in Guatemala, I guess it's not the same thing, but in Brazil, we got very difficult situation with the indigenous people. They proved to be very susceptible to misinformation, and then and actually most of these people are reached by the government, and the government, as we saw, they were actually actors to deliver misinformation. So how could we deal with this? So the community, the scientific community, and the associations, social groups in Brazil, they get together with the Brazilian Articulation of Indigenous People, which is like a huge NGO that represents the indigenous people, and get together with leaders from each of these groups, and got like a huge conversation and trying to listen from these guys, what were their doubts. Sometimes they have like problems with understanding what is going on, if they are safe or not. And then through this, these guys were able to get the leaders, religious leaders or other leaders inside each of these groups, and try to diminish the hesitancy regarding vaccination. But I think it's very difficult, because you should have like some kind of approach that is local approach for each of these points. So the second question is that, we don't have a lot of information for many countries in Brazil. Like, I tried to collect the information that I could get from some studies on vaccine hesitancy. So Dr. Larson said, and one of these was this survey that they did in 2015. And so we have like data for Argentina, Ecuador, Colombia, and Brazil. And these are actually Peru and Brazil and Argentina and Colombia. They are the most populous countries in Latin America. So it was easier to find information about, it's not actually easy, but it was easier to find some information about these countries. But of course, I would like to give a picture for all countries in Latin America, but it was actually very difficult to find. So that is my explanation. It's like lack of information, my information on other countries.
Thank you. And I don't know if any comments about any other place in Latin America, or we can see if there are any other questions that are coming up. It's hard to focus on, it's hard to do the entire continent to talk about every country and its specifics. So we chose to focus on specific countries.
Monica, there is a question from Maria Ocampo about vaccine hesitancy and vaccination in children, which I think the panelists so far have not really concentrated on. Maybe Heidi, Larson, or you would want to comment on that?
And Heidi, I'd love to hear it, because we have had a campaign for children down to 5 actually since November. And I know that it's been a little more recent in different countries that have been opening it up to the 5 to 11-year-old vaccine. For example, South Korea just opened up.
Yeah, it's been very varied around the world. And I think, there's already background anxiety about kids and new vaccines in general. The new ones are always ones that make parents more concerned. I think it really depends on where you live. I think the US has been, frankly, more proactive than other countries with getting it out there for children and promoting it. I know there was in places where they have introduced it, sometimes they're doing really well with COVID vaccination in adults, but then the childhood vaccines don't go as well because it's a different kind of risk threshold, as it were. So I'm sorry, that's not a simple answer, but some of it's cultural, but I think it's also how it's introduced and presented and supported.
I can give a little more specifics about the US, which is that across our states, the Kaiser Family Foundation does track this, and it ranges, the uptake in the 5 to 11-year-olds ranges from about 15% in some states to 65% at its highest in New York and California. And I think it's been stymied by one thing is that some analyses, especially with Omicron, have shown less vaccine effectiveness. However, of course, that doesn't mean that we don't have those underlying T cells and B cells that are produced by the vaccine that you want for a lifetime. And that's why I always start every vaccine talk with reminding us about cellular immunity. But I think it could be that reinfection is more common. Of course, children are less at risk for severe disease, and that is, just simply a fact. And so that has led to the hesitancy. And then I think third is, like you said, these new vaccines. And one thing that I'll say is that Covaxin in India has gone down to the age of 2 and has had less hesitancy. Novavax, I think if it was approved in this country, may, as a more traditional subunit protein vaccine, may have a little more uptake. So it'll be interesting when we get those vaccines here.
Yeah, that's good. Thank you.
So Monica, I see that we're at 7:30. There's a new session starting, but maybe Adeeba, do you have a brief comment?
Yeah, I just wanted to share on our experience with the rollout for the childhood vaccine 5 to 11 that just happened, I think, about a couple of months ago. Traditionally, like Brazil, Malaysia's had very high vaccine coverage for childhood immunization for many, many decades, always up in the 90s. So vaccine hesitancy for children in general has not been a huge problem. But I've just checked the figures on this COVID-19, and overall, I think we're up to something like 50% of children now being vaccinated, the 5 to 11. But when you look at the different states, it does seem like the more conservative states within Malaysia are a bit slower, and I don't know if it's because of less severe disease. They want to wait and see what happens as the rollout progresses in terms of severe adverse events. There's a lot of confusion around the risk benefits for younger children. So much as like I said before, slightly slower uptake compared to vaccination of adolescents and the adult population in general. I think that there is that. Let's wait and see what happens, because children have less severe disease.
Thank you. If there is a question, Larson, maybe you can just write in the chat your thoughts. It was addressed to you, but otherwise,
I just want to, on behalf of CUGH and the University of California Global Health Institute, I really want to thank Monica for moderating this session, and all of our wonderful panelists, literally from around the world, to address this very important issue that continues. And this sort of discussion, I wish we could be in person, because we do need to identify solutions together to help the community in Guatemala and communities in the US and all around the world to address this. SARS-CoV-2 is with us. It's going to be continuing to cause outbreaks as we move into the endemic period, we hope, with other variants, and vaccination is going to prove to be a very important tool for the world in order to address the morbidity and mortality that this pandemic has wreaked on our world. And especially with a view health inequities, a variety of reasons as well. We really need to work with communities. I think that's what we've really heard during this session. So I hope we can keep the conversation going. I believe there's the chat. There's a way to be able to communicate with the panelists on the CUGH website. I encourage you to reach out to individuals and to keep this conversation moving forward so we can find solutions that work for individuals and communities together. Thank you so much.